Greetings everybody and happy holidays. Welcome to our 49th of our Town Hall series. In February we'll actually be celebrating our big 5-0. Today we're talking about artificial intelligence and how it can help improve research and clinical care for our patients. First off, it's kind of ironic as we're talking about artificial intelligence, but as you know, we had a little technical glitch in October. I apologize for that. You weren't able to watch live. Many of you did watch the recording after that. We have those technical issues solved, and apologize for that again. We're using a different platform, and that was what generated that, so hopefully that works well for you today. As always, we'd love to take your questions, so you can text your questions by texting the word DeBakey to 37607. You can also use the live chat box. We actually have Dr. Roberta Schwartz, our Chief Innovation Officer, there, ready to type furiously and answer all your questions. And we're also joined by two really wonderful guests today who are going to speak to us, and then we'll do some Q&A. First, we have Dr. Jordan Dale, who's our Chief Medical Information Officer. And as well, we have Dr. Stephen Jones, who heads the Center for Health Data Science and Analytics at Houston Methodist. They're going to talk about both clinical and research. And I'm going to start first with Dr. Dale, who's going to talk about how artificial intelligence will continue to help enhance the care that hopefully each of you are providing or are receiving.
Thank you so much. So I'm going to jump into just some definitions and level setting before we get into some use cases, because I think it's important with how artificial intelligence has been used in the public media and in clinical care recently. So artificial intelligence is really a very broad definition, and it talks about the ability of machines to perform tasks that are normally done by humans. And you probably have used artificial intelligence by this definition already today if you use spell check on your phone or your desktop. If you've interacted with a chatbot that's helping you, guide through an experience or a process, or maybe if you've used a car that uses object recognition to help with self-driving or assisted driving. So it's a pretty broad definition. Another term that I want to make sure we're all familiar with is what's called autonomy or human agency, something that's paramount in healthcare to make sure that we maintain. And again, I'm using a lot of self-driving car references here because I think that's one that most consumers have experienced. Whether you've used assisted driving, we're just getting nudging for lane changing, or somebody in your blind spot, that would still be considered artificial intelligence. And obviously full self-driving is a little bit higher level and removing some of that autonomy from the driver. But obviously for things that we want to apply to healthcare with patients' care in the middle, we want to try to maintain that human agency as much as possible. So there's a spectrum of artificial intelligence, when we talk about that broad definition, that I also want to orient ourselves to. The newer methodologies, things like machine learning or deep learning, and the things like generative AI that you may have heard of, ChatGPT, Gemini, Claude, other things that have been created by the consumer technology companies, functions a little bit differently. And so it uses a more probabilistic approach to things to find patterns and provide you an answer. That introduces potentially some more risk because you could have multiple correct answers. There's no exact answer like you would get out of rule-based logic or predictive analytics. And so it introduces things within healthcare where we want to kind of monitor that risk by putting a qualified human in the loop. And so that's one of our guiding principles here at Houston Methodist when we're applying these technologies, and something you should think about even in your consumer life if you want to apply these technologies to certain high-risk scenarios. There's also risks with publicly available generative AI technologies I just want to make sure people are aware of. I think I referenced a few examples of where this technology has been abused and misused. So just want to make sure people understand some of those risks with this. That's why we have to have very kind of federated ways that we bring it into our clinical care areas and make sure we manage these risks appropriately so we can maximize the value and impact to our patients. So these are just two examples. Unfortunately, early on when ChatGPT came about, there was an example where a lawyer used this to get some case briefs and present it in the court of law. All these case briefs were hallucinated by ChatGPT and quickly picked up in that case, and unfortunately resulted in some sanctions. So things that we want to make sure that our users, both patients, clinicians, are educated about some of those risks if we were to apply this in clinical care, and ways that we can actually put guardrails where we prevent those things from impacting how we use this technology as well. On the right-hand side, there was also a case where this technology was used for deep faking or imitating somebody's appearance to also make a fraudulent transaction on behalf of a company. And so again, just things that we should be aware of and why we really need to make sure that we're focused on using this in high-value areas where we can monitor the risk and avoid some of these things that have impacted these businesses or individuals. So we've established an AI oversight committee, actually celebrating our 1 year of this committee just last month. And really it's helped mature our approach of how we evaluate these technologies and make sure we implement them in a responsible, trustworthy, and effective way within healthcare. And so some of our guiding principles with this committee that we've developed is ensure a human is always in the loop. Again, we want that qualified human to be in the loop to monitor how AI may augment the intelligence of that individual, whether it's a clinician or otherwise. And then how we can prioritize practical solutions that add true value to our patients and our clinicians, not things that we just want to do to say we're doing artificial intelligence. And we always want to implement technology responsibly, whether that's artificial intelligence or otherwise. And we've moved faster with some trusted partners that you'll see in this presentation as well. So I'm going to highlight some use cases of AI at Houston Methodist in clinical care. We have predictive and proactive artificial intelligence using our virtual operations center that really functions as our virtual ICU, virtual nursing, and virtual platform to provide assistive support to a lot of our clinicians across our enterprise. And it's allowed us to centralize that expertise and leverage artificial intelligence to augment that expertise at scale to provide that benefit, to augment things like night staffing, patients that may be in the emergency room that still can't need a higher level of care. And so it's something that's really transformed how we deliver care at Houston Methodist and paramount to how we deliver care in certain settings today. Other examples that we have is implementing kind of machine vision or smart vision cameras within our inpatient rooms as well. We use multiple cameras from a vendor called Care AI that looks at things, both true video that you're used to seeing that you're looking at right now, but also things that are called machine vision that actually have data overlays on some of that information to tell you whether the patient's moving and maybe at fall risk, and kind of get alerts and alarms in that fashion. And so again, using AI and that camera technology to provide support to our clinicians. In the middle, we've also used things like a bio button that all of our patients get attached to them when they come into the hospital to do more real-time tracking of their vitals and some proactive monitoring for things that we may need to assist them or address in a more proactive fashion rather than waiting for somebody to take periodic vitals. Other examples that we have within the operating room is also, and this is a good example of machine vision and using that object recognition, where we have cameras by a vendor called Apella that's monitoring certain procedures so we can look for process improvement opportunities across these procedures to see if a certain staff member needs training on how to be efficient on laying out surgical instruments or how they wheel in or out of a patient. We're really looking at it from an event tracking and process improvement perspective. And that's where we're able to leverage this technology where it's watching and tracking these in a very unbiased way in terms of how these roles are performing within the procedure. Whereas previously we had to rely on somebody to manually do this, and that just took time away from where they could direct their time to the patient and really the value of what the patient can realize. Other examples where we're using specifically generative AI at Houston Methodist, and these are some examples specifically with our electronic health record vendor, Epic, is where we use chart summarization to really help clinicians get to know a patient faster. So patients have so much data in their charts. You probably appreciate that as a patient yourself, looking in your MyChart or other accounts. So whenever you encounter a new clinician, it can take time for them to get to know your story, get to know some personal details about you, build that trust with you the first time that they're interacting with you, knowing those details. And so we can leverage this technology so that they're up to date on recent events or kind of understand your story from an encounter, and can jump into that interaction with some of that background and trust that they can develop with you a little faster. We're also leveraging this in automated draft replies to MyChart messages. And again, this is with a human in the loop. So both these examples and everything that I've shown implement that, but it's really just teeing up a draft to the clinical staff or the clinician themselves to respond to MyChart messages. And this can be helpful because you may be asking a question that require a look within your chart to see when the last time this medication was filled, what location. Those sorts of things can be teed up into the draft, verified by the human, edited by the human, and then sent to you in a more expeditious way, and provide that benefit and reduce some of that administrative burden that these types of messages have introduced to our clinicians. Other examples that we're using with the vendor called Pieces is to really help use generative AI to facilitate discharge planning on the inpatient side. Again, using some of this summarization technology, but also kind of removing or extracting discrete insights from non-discrete data. So meaning a lot of notes that physicians or clinicians write, it's really hard to pull out specific insights from that information. These notes could be 10 to 15 pages long. And so this technology is actually really good at that, of reading that quickly, pulling out a discharge barrier, pulling out something that's really important for the case management and discharge planning staff, in addition to the physicians to understand, to again make sure that they're representing the patient's wishes and helping to plan that discharge in a more timely fashion. We're also using technology called HDAI to do more predictive analytics at the population level. Again, doing predictive analytics across a lot of non-discrete information like notes and imaging results and things like that to understand the individual risk a patient has for certain scenarios, whether that's readmission into the hospital or success with a given surgery or mortality risk based on a certain treatment or intervention. This just helps us have a more informed information when we're making decisions about the patient. These are all things that are served up to the clinicians, and they're educated on how to incorporate this within their decision making. And I think some of the final examples are focused on ambient listening, something that's certainly been the most broadly adopted, I would say, across Houston Methodist today. And we use two different vendors to help support our clinicians. One that's on the left-hand side, and that's one that we've focused on implementing with a lot of our primary care physicians on the ambulatory side. We just celebrated having over 100 primary care physicians on this platform very recently. And this technology is really meant so that you can have more face-to-face conversations with your physician or provider that's delivering care, and that some of that documentation burden can be offloaded to artificial intelligence. So as you can see, both of these work on mobile applications. The clinician would just start recording after talking to you a little bit about the technology. They press record, and it listens to the conversation that you're having with that clinician and summarizes it into a clinical note that they can then review and submit as your encounter note. I've been highly impressed with how personalized it can get in terms of the patient's story and symptoms, and really reflect that into the note, so that the next clinicians that may be the person taking care of them really know the story with a little bit more detail, rather than relying on a physician to remember how to do that at the end of a busy clinic day. On the right-hand side is a similar technology with ambience that we're focused on using with specialists. We have over 50 specialists on this technology, and also have been exploring using this in the ED for our physicians that also have documentation burden that artificial intelligence can help assist with. And this video is just going to show you how this technology has impacted some of these providers with our early exploration.
Ambient listening devices using voice-enabled artificial intelligence automatically document the essential health information patients share during their exams, rather than the doctor manually typing the information, allowing our providers to be totally focused on their patients.
It's amazing technology. I think that ambient listening has changed the way that we're doing healthcare. When I explain, hey, listen, this helps me talk to you, give eye contact, and listen to you without typing things. Most patients tend to be eager that you don't have a laptop in front of you.
It's made it to where my notes are a lot more clear, a lot more accurate. The patients feel heard because they get their issues addressed. I don't have to spend all that time taking care of paperwork, and I could spend more time focusing on what I love to do.
With this ambient listening program, I'm able to finish all, if not most of my charts by 4 o'clock or 5 o'clock. And it allows me more time with my family. It allows me to engage in my hobbies, whether it's going to the gym or cooking or taking my dog for a walk.
So it has changed my life. Oftentimes I would stay up late or be charting in front of my kids. And so they didn't feel like they were the number one priority at that time. Having that time for myself with my children and my family and my husband, it's so important.
So hopefully that highlighted the impact this technology could have when we provide it to our clinicians. And so just in summary, how we think about artificial intelligence at Houston Methodist is we want to leverage artificial intelligence and all technology to empower clinicians, patients, and employees. And we want to make sure we have a proven track record of how we integrate innovation into our health system in a responsible and trustworthy fashion. So having things like our AI Oversight Committee that I help chair and we've led really make sure that we look at this technology, manage those risks, and make sure they're not impacting how we deliver care to our patients. And then that we have responsible and trustworthy ways that we can deliver this and still receive value. One of the key parts that we talked about was maintaining that sense of human agency or human in the loop when we're implementing this technology to manage some of that risk and make sure it feels like it's an augmented experience, really leveraging that clinical expertise initially and then augmenting it with technology rather than replacing it. And so we don't want to use artificial intelligence as a proxy for human expertise. We still want to support things where we need to have an empathetic or compassionate conversation and not replace that with this type of technology. But there's a plethora of administrative burdens and other ways that we can use this technology to scale skill that we want to focus on and really implement and transform care here at Houston Methodist. So with that, I'll turn it back over to my counterparts and talk about how it's assisting other areas of Houston Methodist. Thank you.
Thank you, Dr. Dale. Well, we'll have lots of questions for you coming up here, but I'm going to turn things over to Dr. Jones.
Thank you, Dr. Boom, Dr. Dale. Excellent presentation. It's my pleasure this morning to present to you on how we're using artificial intelligence in research itself and how we're using that to improve patient care. At the end, I'll close off with a somewhat aspirational future state of where I think we can head with this technology into the future. Artificial intelligence is accelerating medical research, drug discovery, and development. Three broad categories that this is ongoing today is in target identification, where AI algorithms are analyzing vast data sets of genomic, proteomic, and clinical data to identify promising drug targets for disease. This is especially important in the realms of cancer and in antibiotic development. This speeds up the traditionally slow and expensive first step in drug development overall. Marc and Dr. Dale may remember when we were in residency, the pharmaceutical companies were telling us that the pipeline for new antibiotics, let me put a time frame on this. I was in residency in the early 90s. So in the early 90s, the pharmaceutical companies were telling us that the pipeline for new antibiotics was essentially drying up, and that it was possible in our careers that we might not see more than 5 or 6 more new highly effective antibiotics, which was terrifying, given the fact that drug resistance is a very real problem. Fortunately, the development in AI algorithms has helped us improve on that situation and made it possible for scientists in industry to identify better targets and pursue a target-rich environment. Instead of a stab in the dark, it is a much more directed, educated guess. The next bullet point I want to discuss here is that AI model is in lead compound optimization. AI models predict the properties and efficacy of potential drug candidates, helping researchers select and optimize the most promising leads. This is extremely important in cancer therapy and will also allow us to find new uses for existing medications that we understand what their mechanisms are, what proteins they interact with in the body, and how they have their impact on disease. We have a lot of work in that space going on here at Houston Methodist, actually. The last bullet point is mostly in the realm of the pharmaceutical industry, where they are tasked with designing clinical trials that investigate the safety and efficacy of the products and the medications they want to bring to market. In this space, AI itself is able to leverage the tremendous volume of real-world clinical medical data to help identify patients that would be the best candidates for participation in these trials, to help ensure that all patients are represented in the research data, because that's been a problem historically. It's a problem now, but going forward, we're aware of these things and can help correct for that bias, and thus derive more generalizable results to help more people down the road. Artificial intelligence is also accelerating medical research and personalized medicine. And from my perspective, I think this is where it's really going to get exciting and incredible for what we will be able to do in the future. Predictive modeling are AI algorithms that analyze, I lost my screen, hang on, there we go. Predictive modeling are AI algorithms that analyze patient data, medical history, genetics, lifestyle, to predict individual disease risk and treatment response. This enables personalized prevention strategies and treatment plans. This is extremely helpful in the realms of surgical planning. How do we optimize the surgical plan when we're trying to remove a debulk tumor, for example, especially in the realm of brain surgery? Brain metastasis is a huge problem, and I'll mention a tremendous project that one of our investigators here is attempting to put together. The second bullet point is precision diagnostics. AI tools assist in diagnosis and classification of diseases by analyzing medical images, pathology slides, and other patient data. This leads to earlier and more accurate diagnoses. My personal interest in this space is I did a lot of research in sepsis and the continuum of that sepsis is. And one of the main challenges we face in sepsis still to this day is that there is no blood test for sepsis. There's not a biomarker. There's no way for me to order a test and get an immediate result that tells me that this patient has sepsis, which has tremendous consequences in the long-term outcome, medium, short, and long-term outcomes of how that patient's trajectory might be through the system. AI will help with this. And as a matter of fact, I think the FDA just cleared the first algorithm for the detection of sepsis. I want to say it was September. It might have been in November. It was very recently. So these things are coming to bear today. Extremely exciting going forward. Artificial intelligence is also assisting in this is something where the majority of what you see at the bedside and available for deploying in the clinical realm right now is in the automated image interpretation, where AI algorithms analyze medical images, X-rays, MRIs, CT scans, ultrasounds, all of them, to detect abnormalities, qualify disease severity, and to assist radiologists in making diagnoses. This is an incredible advance, and it's hard to overstate how important this is, and in general what computer vision is going to be able to do for us as we advance through history and forward in time. Image enhancement. AI techniques improve the quality of medical images, making it easier to identify subtle details and abnormalities. They're very good at edge detection, very good at predicting things subtleties in the data that may not be visible to the human eye. That brings me to the point of, I didn't want to just take a moment just to discuss what it is that computer vision really means. When you think about what we can see in the world around us, that visible light is a very, very tiny fraction of the entire electromagnetic spectrum. To put that in context, the electromagnetic spectrum ranges from very, very long radio waves. Some of them may have a length the size of the universe, literally, and to the very, very short gamma rays on the other far end that are highly energetic but incredibly short wavelength. The visible light spectrum, out of that whole range, is the width of a human hair. That's all it is. The spectrum is amazingly broad. To put that in like a real world context, if you were to take the distance from coast to coast of the United States and put a human hair on it, that's how much of the world we can see with our eyes. Computers don't have that limitation. We are able to build sensors that are looking into things that are not visible to the human eye, and then apply AI algorithms to detect what is salient and important in the data that it has access to, and then visualize it so that the clinician and the scientist at the bedside can see it. And using that information going forward, combining these modalities and bringing them all to bear at the bedside is absolutely going to improve healthcare. The last bullet point on this slide is that AI extracts quantitative information from medical images, providing valuable insights in disease progression and treatment response. It lets us know if, for example, is chemotherapy actually having an effect? Is that tumor size really decreasing? What are the other properties that are we looking for? Is it less dense? Is it more dense? Changes in the quality of the image data itself. This actually applies really, especially in the beginning of medical training or as you're becoming a scientist, in that AI is extremely good at summarizing, and Dr. Jordan mentioned that it's at summarizing charts. The AI tools analyze vast amounts of biomedical literature and data to identify relevant information, extract key findings, and discover hidden patterns. We can use large language models to help us summarize the medical literature to rapidly bring us up to date on what is going on today. And using these tools, we're also able to segment easily how things were 20 years ago or 30 years ago, and then compare them to what maybe advancements have been in the last 6 or 7 months, to ensure that we're not just looking at the average, we're looking at where things are today and where the trends might be headed. The last bullet point is hypothesis generation. This is where AI can help researchers formulate new hypotheses and identify promising research directions by analyzing existing data and the literature. Essentially, the AI can look at the data set and tell us and suggest questions that might be worthy of exploration. That's in research too. There is a human in the middle. There is a human in the loop. AI isn't conducting its own research at this point. Well, let me correct myself. In some cases, it is, but in the majority of use cases, AI itself is not responsible for conducting the entire experiment or even coming up with hypotheses to be tested. That's where the human in the loop comes in and says that's something we should chase, and then we go after it. The surgical planning, the use of artificial intelligence in surgical planning is game changing. We're using it here for liver transplant, for example. We get 3D images of liver, of your liver, if you needed a liver transplant, or if you had a lesion in the liver need to be removed. So this is personalized medicine as well. And we're able to combine the modalities from CT, MRI, ultrasound into one image to help provide the majority and much more complete picture of what is likely going on, so the surgeon isn't surprised when we go in there and see what's going on. Dr. Dale may remember too, when we were in training, it was often a surprise. We did our best to understand what was going on in the patient, but we couldn't really tell what was going on until we got inside. AI is decreasing the amount of surprises we run into. And really, the tremendous amount of data that is going through these systems now is letting us know what you need versus what the average needs. And that is personalized medicine to a T, and will truly and dramatically impact outcomes for each individual person now and in the future. Surgical assistance. This is something that touches me personally. I have a 55 megahertz tremor, and I really wanted to be a neurosurgeon. That's what I wanted to be growing up. And but because of that, nobody wants anybody with 55 hertz tremor operating on them in any way, shape, or form. It just wasn't an option for me. Again, being a little bit too old, the robots that we use in surgery now today are 100% capable of subtracting things like that out of the equation, so that wouldn't hurt somebody. But that's just a me story. The better part about the surgical assistance is that the robots don't fatigue. They are able to move in ways that humans cannot articulate. They can get into small spaces that our fingers and instruments just won't fit, because the robots can be designed to get in there and do microsurgery in areas that were fantasy even just a few years ago. That's a segue into the minimally invasive side. The future will be much less invasive. Much more minimally invasive, but less invasive is the easiest way to describe it. Because as you know, the difference between surgery and an unexpected trauma is that you know what's happening. The body responds in the same way. If we are able to minimize the amount of damage we're doing to a person to help cure them, that is better for everyone all the way around. Now this is the fun part for me. This is where I get to talk a little bit about some of what our teams here at Houston Methodist are doing in the realms of AI research and how they're using it to help them raise the standard of care and lead medicine. Stephen Wong is one of our rock star data scientists and scientists overall, working with the Cancer Center now. He, along with numerous collaborators within Houston Methodist Hospital System itself, the Neal Cancer Center, Neurological Institute, and Internal Medicine, and across multiple renowned medical centers, including MD Anderson, Texas Children's, Jackson Lab, and the University of Connecticut Medical Center, are currently actively using AI to tackle complex problems in medicine in these categories. These are just three. Dr. Wong sent me a real long list. They're looking at lots of different things. Drug discovery and repositioning, biomarker identification, touched on that a little earlier with my personal interest in it for sepsis, and just general clinical research in overall. Oh, I take a little segue here too. You might have noticed these images all have a similar, style to them. And in full disclosure, these things are AI generated. Every one of these images that you've seen in this presentation was generated with a prompt and a lot of back and forth dialogue with several different AIs. They're all not from one. So this one, I literally took what you see on the text there, asked it to generate me an image that illustrated this. And this is the only one out of all of these that was rendered on the first prompt. Most of them require quite a bit of tweaking. But if you can see the image close enough, you can see some details where AI messed up. I left them in there on purpose, because this is just an example of how AI is not always right all the time, and we need to be skeptical. We don't need to look. We shouldn't be looking at the results of AI and then trying to just go, is that right? That's called confirmation. That's confirmation bias, and that generally is not the way to approach AI output. AI output should be viewed with healthy skepticism. And with healthy skepticism, you challenge it and you test it. It's different from looking to see, oh yeah, that's the same source that the AI interpreted, and it's also wrong, and here we go. So that's why the role of the skeptic is important now, as it always has been. And these are some of the actual projects that are going on in Dr. Wong's lab. He has an AI-enabled breast cancer risk assessment. It utilizes image and omics data, combines the proteomics and the genomic data with the imaging data, or in each individual case, to reduce the over biopsy and over treatment of lesions that we see on the various modalities that we use that may not need any treatment. Now, because anytime we instrument a patient in any way, shape, or form, there's risk associated with that. So anytime we can reduce the need to do that in an actionable, verifiable, safe way, that is something we should pursue, and that's what that project is about. Stroke triage and diagnosis, multimodal data integration, video, voice, and CT images, and a timely stroke intervention, and to reduce misdiagnosis in ERs and mobile units, along with the stroke center here. That's fascinating. I've been dealing with that in my family now, and I cannot wait for this thing to be brought to the bedside to help other families in the future. AI-guided cerebral angiography. I mentioned earlier my 55 hertz tremor problem and how you wouldn't want somebody like me driving that. But with AI, I could. Digital radiology and pathology, biomarker identification, disease stratification using AI. Virtual screening and physical therapy, automating physical exams such as NIH stroke scale. That's the NIH-SS, National Institutes of Health Stroke Scale. And enabled virtual physical therapy for home monitoring. Dr. Sadir Al-Kindi, and this is also, for me, really where we start to see where computer vision can help advance the field. Dr. Al-Kindi and his team are taking data that helps us develop something that is broadly referred to as the exposome. And what is that? What that is a history of what a person has been exposed to in the environment. We all understand that genetics is the foundation of what the environment acts upon, but how do they interact with each other? It hasn't been possible up until now to be able to pull all these data sources together, like information about what kind of industry is going on, what kind of environmental information we have about where people work, live, and play. Bring that together, put a lifetime story together. Over time, we will be able to do this, that will predict what your risks are and what things we can do to mitigate the risk of, to help you optimize your health. Dr. Salil Al-Kaman and the Department of Radiology and Dr. Diego Martin are using AI for advanced image analysis across several subspecialties. They're collaborating with Rice and RICU pulmonologists for predicting acute respiratory distress syndrome in adults. That's predicting so we can potentially intervene and prevent that from occurring would be a great benefit to our patients. It's a tremendously morbid problem. A neuroscience imaging with Dr. Steve Fung and the functional MRI for the brain. This will be utilized to enhance resting state or non-task-based functional MRI. This will help us better understand the numerous pathways in the brain. Our brain is an incredibly complex organ, and by understanding how information moves from one part to the other for different tasks, we will better be able to inform what a rehabilitation program should look like, for example. Brain doesn't regrow, but it does rewire. Last but not least, this is a personal aspirational goal of mine. If you look at this, this is also an AI-generated image, but this one I did tweak. The other ones I didn't. The idea behind this is I asked it to generate an image that depicted you in the center of your own healthcare. So imagine a personal health ecosystem where you are empowered by AI to take the very, very, very best care of yourself and your loved ones. And this information is available to you in the palm of your hand. The big data, artificial intelligence, and machine learning is the future now. In early 2020, Houston, just before the COVID-19 pandemic struck the world, Houston Methodist began its long journey towards building an information technology infrastructure to better support big data, artificial intelligence, and machine learning. These tools and technologies are essential to Houston Methodist's future, leading medicine. Leading medicine isn't just a slogan for Houston Methodist, it's a promise. And part of this process includes our embracing these new technologies and bringing them to the bedside to better take care of the community and the patients that we serve, and to also empower you at the end of the day. I think lastly I'll wrap up on this one, Marc. When you think about how artificial intelligence works, the data sets that it has access to, and what we're doing with it, the vast majority of the data sets in healthcare that are being used to train and develop these models in AI come from patients that have been in the acute care setting or chronically ill, chronically challenged medical patients. That only represents about 15% of the population. So all these models, by their nature, are inherently biased. They're biased with data from people that are suffering from one malady or another. That isn't the majority of the data about us as who we are as people. The majority of that data comes from us living out in the real world, living our lives. For the first time in history of the species, we have large chunks of the population that are instrumented. I've just been taking my heart rate this whole time, and Google knows where I've been for the past 10 years, and we could put all that information together finally, and use this information to build a system that empowers you and you to take care of yourself and your loved ones as we move on down the road. I'll skip this one, Mark. This audience probably doesn't care about the 5 V's of big data. Maybe there's 7 today. I still think the 5 are the right ones. And this is my last slide. We want to build just imagine a world where we have empowered people to take the best care of each other through just data science and AI. A personal health ecosystem is an integrated network of health-related devices, applications, and services that collectively support an individual's health and management. It combines information from wearable technology, electronic health records, telehealth platforms, state-of-the-art evidence-based practice, and data analysis tools and predictive AI to provide personalized real-time insights and connectivity to healthcare resources, both preventative and therapeutic care. I think that's it.
Thank you. Well, thank you very much. Lots of interesting questions have been coming across, so I'm going to try and keep us moving and get to those. I'm going to start with a couple of the big elephants, or really the questions I get asked every time that we're talking about AI. I'm sure you all do too. So start with Dr. Dale. So who's this going to replace, right? That's one of the first things I always hear from employees, physicians. Is this going to somehow replace my job? Where do you see that going, and how does that affect the employment side of things?
Yeah, absolutely. And yeah, I think it is a common question. And I think hopefully the examples that I shared were highlighting that we're not going to replace, people or expertise that we want to keep at the bedside or interacting with our patients, but hopefully reduce unwanted work that those people are doing, right? So I think there's common stats of for every 1 hour of face-to-face time that you have with a patient, there's 1 to 2 hours of non-face-to-face time, which is just administrative work, right? Generating that note or doing prior authorizations or putting in orders. A lot of that unwanted kind of administrative non-face-to-face time could be reduced by artificial intelligence. So that's our goal, that's our focus here at Houston Methodist. I think the other way that I highlighted too is that how can we upskill some of our newer clinicians, right? New physician, how do they operate, like a mature physician or a new nurse? How can we get them to, work or function like they've been doing the job for 5 years? So I think we're looking at ways that we can accelerate their skill development and reduce some of that administrative burden, not replace people.
So taking the nurse one, I mean, it's almost like you can put, or a physician early in their career, you can almost put the senior physician or senior nurse on their shoulder, basically looking over everything they do and helping them, whispering in their ear, effectively helping them really function up a level, is what you're saying. So
absolutely.
I'd comment a couple of things. One is, when we've set the institutional priorities around this, we've said we want this to obsessively focus on our patients, on our customers, on our communities, and the people we serve. So the reason we look at all of this is how do we do better? And then very, very close second is how do you improve the life of the people providing the care? And I think the video you showed really captured that very nicely. And I will say I'm one of the 100 primary care physicians who's been using the ambient listening and just used it in clinic 2 days ago with 2 of my patients. And it's kind of like a wow, gee, whiz bang kind of thing with a lot of the patients the first time they see it, because I'll show them, because I want obviously there to be trust in the system, and I'll ask their permission. I'll hit the button, and we'll have a 25-minute wandering conversation covering all the social issues. I mean, most of my patients I've known for 20 years. And this thing will then give me the most crisp summary of the relevant parts of our conversation in an organized fashion, the way I was taught to do it in medical school, right? Is to sit there and introduce the person, and each paragraph tackles a different problem and has all the related things. It's really very elegant. And from a patient perspective, that has improved the experience dramatically. Number one, I'm sitting there looking at them the whole time. And number two, instead of me at the end of a day, if I'm a really busy clinician, sitting there going, oh shoot, what did we talk about? I have to make sure I get all the nuances. It gets all the nuances. Maybe at the end of the day, I'm just sitting there typing a little code in, and it populates that and sees it. And so it really does fire on that first goal. But as an example, it fires on the second goal as well, right? Because it makes my life as a clinician better. You heard that from those primary care physicians. They're not sitting there with their kids at 8 o'clock at night all watching TV, and they're on their laptop finishing their charting, which is obviously, we want people deriving joy from the practice of medicine. So that's actually good for the people who receive care as well. So I think that's what you're saying here as we think about a future. Well, let me ask the kind of other thing we get asked all the time is, this is a lot of data. I mean, now you're talking about, we know everything. Google knows where you've been, everything else. We probably have some of the most sensitive data that's possible to be out there about any human being.
Yeah.
What do we do to safeguard that? How do we both make sure we're safeguarding it in general, and then how do we make sure that it's not being used from an artificial intelligence perspective in ways, obviously none of us would want?
Those are fabulous questions, and I know the heart of our organization is all about that. How do we protect our patients, keep them in the center first? So there's a lot of technical solutions to what you're talking about, and all of the state-of-the-art technical solutions to protect our data from unauthorized access and use are deployed and constantly monitored and put in place every single day. The social side of it is a very real problem too. There are different ways to get on the inside without, so you circumvent all these technical things. We have a very robust program at the hospital itself to keep all of our users in the system aware of this, and we're well educated and on the lookout for things like that. Beyond that, once you get to the data itself, we have very robust systems in place to ensure that it's properly handled and managed. There's numerous processes. We have an institutional review board that reviews and authorizes and considers from a scientific perspective, a patient safety perspective, ethical perspectives, whether or not the research itself should be undertaken at all. Once that authorization is approved, there's another process for getting access to the data itself that involves ensuring those things have all been checked off, and then we're able to proceed. We have robust mechanisms in place to de-identify the data where appropriate as well. Even Dr. Khalil's lab has the ability to take your face out of the bones of your face out of a CT or an MRI, for example, because it is possible to regenerate a face from just that. And so those things are all thought of, and we are very, very vigilant about this stuff. We take it incredibly seriously.
So, very importantly, a lot of the uses use especially when we're studying things, use de-identified data.
Yes.
Correct.
Yes.
So, I mean, everything we're thinking about everything that could be used, and really, you need the large amounts of data to study and build the models and everything else. You don't necessarily need.
You need who the person is. You really
this
don't.
Is person A, B, C, or D. You might, obviously, if we're now focused on you and your personalized medicine, that's a different story.
That's correct.
That's a different use case. But when you're talking about how we're going to use this to improve care in general, most of the time the data is very meticulously de-identified to utilize it. So, well, I guess I'd make the comment that, all of this is happening. It's moving probably faster than it's going to get regulated, and where else are you going to trust more than a place like Houston Methodist that's faith-based, that's got our eye care values, that integrity is the first one of those eye care values. And so, our pledge to you is that we are going to do everything we can to use this in the most ethical manner, but we need to all put the foot on the gas also to capture the benefits of this, right? We don't want to let fear of some of the unknowns slow down the fact that we can actually use this to really improve care. So, I'm going to come back to this people question. So, I have one kid in med school, one who's a resident. Radiology, digital pathology. I mean, do we need all these radiologists someday? Do we not need all these radiologists? I mean, those are the kinds of questions everybody keeps asking.
And I think everybody's already saying right now we don't have enough, right? So I think it may help address how we extend these people in with their skill in the workforce, or can we augment them so they can take care of a larger amount of patients and things safely. I don't think it's looking of saying we're going to start reducing number of pathologists or radiologists that go into training. We just can't get enough people to go through that. I mean, I think you saw the big turnover on the nursing side in the pandemic of even just the acute care nursing staff now. Most of them have less than 5-10 years of experience, right? Because there was a huge turnover. And so we need to address accelerating their skill development. I think it's the same way on the physician side. I think the counter to what you're saying, though, is that I don't think there's any clinician that's going through training right now that can say that they won't be using artificial intelligence every day to take care of patients. And if you use that broad definition, again, they probably already are. So there shouldn't be some concern and kind of barriers put up to understand it, right? You should really understand this technology, understand how it can benefit you and in your specialty, and make sure you're part of this conversation that we're having here, right? And if it's not happening, at Houston Methodist where you're doing your training or having that experience, make sure that there's these forums where they're having this discussion about responsible, trustworthy use of technology in general, including artificial intelligence in the future.
So, I always talk about the value of the word and versus or. This is a classic and. This is not an or. It's not, will we have the machines doing it or we'll have people doing it. We're going to have an and. I mean, it's going to be both, and it's going to make the people part that much better. When I go back to those two key goals of really, making the lives of our clinicians better, and really the goal of that is to free them up to do the things that human beings need to do, right? Praying with you before surgery, having compassion and being there for you and listening to you, those are not things that are going to be, certainly I don't think in my lifetime, being done by the machines and the computers for us. But you know what, doing a lot of the grunt work and the scut work and the things that really don't build that relationship are, if you think at a very broad level, and you look at the next, we're entering 2025, so you think in terms of quarter centuries, you think about the next quarter century, the 18 to 64-year-old work group is going to grow by 4% in the United States. 4. The 0 to 18 actually shrinks by 6%, so it's actually going to get worse in the next quarter century after that. 65 and up grows by 40-something%. 85 and up grows by 168%. Guess who's in the hospital, right? Obviously, who still gets admitted, once a year, twice a year, sometimes many times a year if you're an older, sicker person. So right when we're going to have all these people aging into that, we've got a workforce that's going to be flat. Now, there's some other things we can do in terms of good immigration and other things that can help with that. May need to redefine the age we all work till, but we're going to have to extend the people who work here and help make them more efficient and connect them to things only people can do. It's an imperative, actually, not just a desired outcome.
Absolutely,
Yeah.
and I think we know a lot of people that have that desire to continue to work and provide that benefit to patients, and so I hope, incorporating this technology will enable them to be able to do that more so than they could, 10, 20 years ago.
So I guess the question for you, Dr. Jones, I was, 2-3 years ago, a group of CEOs and I were, it's like 7 of us meeting with the medical director of Google, who was walking us through teaching their large language model, teaching it to basically pass the medical boards. Yeah. It took them 9 months. The first time it took it got like a 40%. By the end of 9 months and a few iterations of the model, it was getting a 92 or something like that on the medical boards. Which of course then begs the question of how is this going to get used in diagnosis for people, particularly people with sort of perplexing and complex diseases? How do you see that happening?
That's a great question. There's two things that I think the theme that both of you have been discussing this whole hour is that we're trying to put the art back in medicine, and that machines are good at numbers. Let them do that, and they're going to need input from us on how to use those numbers, but let the people do the people part, exactly like you just said. Bring the art back into medicine so that time with the physician and the patient is human to human time. Let the machines do the machine stuff. And for the first time in our history, we're at an opportunity where healthcare can actually lead this. We can use the data sets that we have, bring in the teams of people that can create these things with a focus on solving problems in healthcare rather than a profit motive. And it's going to happen both ways. It's going to both in parallel. That's fine. But right now we have an opportunity to lead the development of artificial intelligence and how it is applied and used in healthcare itself. From what are the problems in a healthcare perspective instead of what might be a profit motive. Back to your question, or back to your statements. In the future, how is these things going to help with the diagnosis? The way these models work is very similar to how you learn to ride a bicycle. Now I'm going to try to put this in human terms, but it's very similar. And that's also, it makes sense too, because we built the AIs to think like we do. The very first time you learn to ride a bicycle is really hard. You have to think about everything you're doing. You fall down a lot, scrape your things. That's all conscious thinking. That's what AIs are right now. That's the first pass through the model. When they're building deep neural networks, they start at the end. What's the end result? Riding the bike smoothly in this case. And what's happening biologically when you're doing this, neurologically when you're doing this, is that it's becoming subconscious and autonomous and going into the second brain, the cerebellum, that coordinates all those motions. That's what these models are doing. They're just figuring out how to weight what is important to keep the bicycle upright, how to weight what's important in making the right diagnosis. Is it sepsis? Is it cancer? Is it cholecystitis? What might it be? Because the problem that you're describing is the fact that we have a very limited range of symptoms that have to describe every single potential medical malady that a human being can have. So there's a limited range there, but so many thousands and millions of things that lead to that eventual outcome. When you provide a deep neural network or these many of the technologies that go into this artificial intelligence, the massive piles of data, the more the merrier. There's no such thing as too much, especially when you're trying to train these things. They can see patterns that we can't as a human fit in our head at all. That's part of computer vision too, is that it's able to see things like your exposome and in a way that a human being can't do. That let the machines crunch the numbers, present the salient information to the providers at the bedside so they can make that human connection with our patients and improve their care.
I think it's also going to add more emphasis on critical thinking and reasoning, right? I mean, they're really good at taking the test, getting the answer. If you ask how you got the answer to question number 4, it might not understand how it, because it's basically just predicting what you think or it thinks you want to hear. And so I think that's the step where we can still have an active role in that and really focus and train individuals on how to be critical thinking and reasoning, keep that sharp. And to your point, things that are just, I need the answer to help incorporate that into my reasoning. You can use these tools that way.
100%.
But I don't think it's ever going to be directly, diagnosing things without, kind of informing the clinician. They might incorporate that or ask, in this scenario, are there 3 other things I should be looking at and incorporating that into their reasoning. It's something I use on the consumer side. If I have family visiting Houston, I might say, I've got family visiting for 3 days. What should I do with them in Houston? Because you forget, the different things that people may want to experience when they're visiting with you. So that would maybe be a similar encounter that you'd have with a physician asking, I think I need to do X, Y tests. These are my leading diagnoses. And then I might say, Dr. Dale, you got to think about these 2 things as well. Mm-hmm. And again, it's using that coaching, to really make sure that your reasoning is staying as robust as it should.
That's how I've thought about it. I mean, obviously, I think a lot of times, the lens of a primary care physician, clinically at least, and one of the things I love about internal medicine primary care is, you often get, you see a lot, but you also often get the big, broad possibilities, and your job is to be detective and narrow it down, mm-hmm. right? So most physicians, I think, sort of quickly formulate a sort of working hypothesis, and then they sort of test off all the different data points against that. The challenge, I think, what we often see with that is they'll go down a bunny trail sometimes because they're testing it, and that kind of fits, they keep going. I see AI as, being that kind of probabilistic model that says, hey, we just got an extra data point. This mm-hmm. thing that was 1 in 10,000 just went to 1 in 100.
Yeah.
Maybe you need to pop that up on your list that you wouldn't even have thought about before, and those kinds of things to make people better clinicians. Is that a logical way of thinking about it?
Absolutely.
Is that exactly what you see?
Yeah, absolutely. I think that's where you see people using it in consumer side to help with, papers or other things and look at problems. And I think it's natural to fit into clinical reasoning that way.
You touched on it a little bit, but we got a question over the wires here that was, is this going to make healthcare more expensive or less expensive?
Sure.
We don't see a whole lot of things unfortunately out there that tend to decrease the cost of healthcare. Are we going to finally see something that actually helps bend the cost curve for us?
Yeah, I certainly hope so. I think, as we were talking about, if we can address some of those workforce needs, right? So extend the people that are skilled and already trained in the workforce, that's naturally going to help us with turnover of staff and retraining and bring people back into clinical care. I think it also might excite people to go back into this workforce, right? As I said, there's a lot of administrative burden to take care of patients, even if you're passionate about doing that. And so if they're seeing these things like ambient listening and other things that can reduce that burden, and you can focus on taking care of patients, having face-to-face interactions, the reasons that people go through clinical schooling, I would think it would invigorate people to go through that. Now, I think the other side is that technology is still relatively new, and certainly 5 years ago, the cost of using this technology was high. There was a high threshold to even start exploring it. That has rapidly come down, and even these 5 years, and just like other technology, we expect it to come down more and more, and some of these things cost an extra $1 or $2 to generate some of these insights. I expect that to go to cents, right, within 2 years. And so if you're getting a benefit, you really only have to show additional value of very small margin to introduce this at scale. And so I do think if we're able to have those workforce impacts, we'll be able to reduce costs just from turnover, keeping people in the workforce either longer or getting them to a high skill sooner, and be able to have them extend that to more patients under their care as well.
And a much harder space to quantify on that is what these algorithms are going to help us do in preventing future encounters that didn't need to happen. And that reduces healthcare costs like you wouldn't believe. And that's again, it's a potential, as Darrell put it. It just means you haven't done it yet.
Yeah.
If it is coming.
But that literally is the, hey, this individual's probability of having some bad event happening or something occurring is going there, knowing that in real time, and them and their doctors and their health system and others being able to manage that, manipulate that, and hopefully keep them healthy for much longer. So lots of very lofty, ambitious goals here, and I'm very, very optimistic about what the future holds. And I will tell you, again, personally experiencing this, what we hear from all of our folks who are already using AI in what are, I think we're going to look back and say pretty rudimentary forms still here, are already experiencing a great deal of positive in terms of clinical output, in terms of their lives and managing our patients. And so lots of exciting things to come. Thank you both for a very stimulating discussion and very excellent presentations. I'm going to give you just a very, very brief Houston Methodist update. One very exciting thing I want to update you on is a leadership announcement. We have a soon-to-be new Chief Academic Officer, as many of you know, Dr. Dirk Sussman, who actually many of you got to know sitting here in COVID with me, giving sage advice and a sort of dry sense of humor as he dealt with some of the sage advice and challenging things we saw out there, is retiring in January. And we've been doing a national search, and just delighted to report that Dr. Jenny Chang, who many of you may know already, is going to be our next Chief Academic Officer. We did a national search, had stellar candidates coming in, and Dr. Chang won out. Dr. Chang has been heading our cancer center, the Neal Cancer Center, very ably, and has really moved that across our system, has really engaged and created access to clinical trials really across our system, has a vision of really how do we become really the very first effective academic health system, not just academic medical center, and just very excited to see what she's going to accomplish. She's already jumped in, attending my team meetings, attending board meetings, everything else as of last week, and mid-January we'll take the baton with a very smooth handoff from Dr. Sussman. So if you see Dr. Sussman, please thank him and congratulate him on his retirement, and if you see Dr. Chang, please congratulate her on really a well-earned promotion. We're delighted to have her in this position. Lots of moving pieces around the system. I'm just going to give you a quick couple updates. One of the things we've been doing is starting to build comprehensive care centers as we've grown and aggregate a critical mass of physicians, the ability to bring together multi-specialties together in really areas that sort of fit some of the internodal points among our hospitals, so that shorter distances to drive, a lot of efficiency, and coupling that with a whole array of different potential services for our patients there, whether that's imaging or physical therapy or infusion therapy for cancer, or obviously a diagnostic laboratory, potentially even some ambulatory surgery centers and other things. It will vary by location. We just broke ground on one of these in Cinco Ranch. That'll be done by the end of the calendar year. One of the things it takes to provide great care is to continue to have great, engaged, happy employees who come here with passion and purpose. This is our internal survey we do using an external company on employee engagement. Again, at the 96, 97th percentile, pretty much year in, year out. And so very happy to continue to have such wonderful people here providing care for you. And in that theme, Forbes magazine actually did a survey of college students of where would you dream about going to work, and we made the list of America's dream employers. On the safety side, twice a year they grade all of our hospitals. This reads left to right twice a year. Straight A students in all of the safety metrics around here. And Newsweek just named us the best hospital in the state. Some Newsweek, U.S. News, they all agree. Best hospital in the state. Glad to see that. So I'm going to finish today with a happy holidays. I wish everybody just a wonderful, wonderful, blessed holiday season, a brand new, shiny 2025, and hope that 2025 brings many of your hopes and aspirations and dreams. And we'll look forward to seeing you in February with our 50th of these Town Hall series. Merry Christmas, Happy Hanukkah, Happy Holidays, Happy New Year. Wish everybody a blessed season. Thank you.